Thank you for joining me today. Um, we're going to be talking about taking a deep cleansing breath, updates in the management of chronic sinusitis with nasal polyp. So I am Joseph. Joseph Hahn. I'm professor of otolaryngology, head and neck surgery, the chief for Division of Rhinology and Endoscopic Sinus and Skull-Base Surgery. I'm also the chief for the Division of Allergy at Eastern Virginia Medical School in Norfolk, Virginia. For full disclosure, I am a consultant for AstraZeneca or these companies. And most of the work that I've been doing are doing a lot of the clinical work looking at biologics for chronic sinusitis with nasal polyps. So you'll see a lot of my name as one of the authors or lead authors for a lot of the papers that we're going to hear about today. So these are the learning objectives. So we're going to analyze the phenotype and endotype of chronic rhinosinusitis with and without nasal polyp, which is one of my thesis. And then we're also going to look at the efficacy and safety data looking at biologics for chronic sinusitis with nasal polyps. And then at the end, we're going to talk a little bit about shared decision-making process for our patients with nasal polyps. And to determine, do we use biologics, surgical interventions, or other treatment options? So we'll talk a little bit about that at the end. And, I will, and I'm very glad that you're here joining me today. And, I want this to be very educational. So I'm going to go through a lot of the slides. And if there's any questions, feel free to put those questions in the chat box, and I'll answer those questions at the end of the presentation. So let's go ahead and start the presentation with a pre-test polling question. So here's the question. The primary cytokines involved in type 2 inflammation, the most common endotype in patients with CRS are number 1, interferon gamma with IL-2, TNF with IL-6, IL-4, IL-13, and IL-5, or IL-17 and IL-2. So you can kind of pick by clicking on the button on the circle on the side and submitting it. And so let's see where things go. So we're looking like it's kind of split between item number 1 and item number 3. Okay, let's go to the next question. Which biologic showed improvement in nasal polyp score by greater than 2 points in close to half the patient population in weeks 24 and week 52? So the first one is benralizumab, second one is dupilumab, next one is mepolizumab, and the last one is omalizumab. Okay, interesting. Interesting. All right. Let's go to the next one. What is the most commonly observed treatment emergent adverse effect in the clinical trials for biologics studied in chronic sinusitis with nasal polyps? Epistaxis, local injection site reaction, nasopharyngitis, or abdominal pain? Okay, interesting. All right, let's go to the next question. Mr. Brown, a 42-year-old male patient with severe chronic sinusitis with nasal polyp, returns 12 months after endoscopic sinus surgery complaining of persistent symptoms. You suspect that nasal polyps have regrown as a type 2 inflammation, which is a predictor that the polyps will return in greater than 50% of the cases. So disease scoring systems showed some improvement, but do not meet the euphoria criteria for adequate response. So what would the euphoria recommend, the euphoria guideline? Okay, interesting. Okay, let's go to the last question. Feeling discouraged, Mr. Brown says if the nasal polyps are just going to grow back anyways, he doesn't want to go through all the expense, pain, and downtime of undergoing sinus surgery. So, in this shared decision-making process, what is the best action that you should provide for him? One, advise him to reconsider sinus surgery because 30% of patients do not require repeat surgery. Appraise him of the guidelines and recommend him to decide between the two options. Give him information about all the available biologics and ask him to choose one, or letting him know all the therapeutic options and the pros and cons of each. So, okay. So now that we're done with the polling question, let's go ahead and go to the next. Let's go to the case presentation. So here's a typical patient that usually presents in our office with nasal polyps. So Bob is a 45-year-old male with a history of nasal polyps. It's not surprising that he has comorbid asthma. And he states that he feels like he's had polyps that have gotten worse in the last 2 months. And obviously his symptoms are not well controlled because he requires systemic steroids. He's required oral steroids in the last 2 years. He's been doing saline irrigation nasal steroid spray and still feels like he's not under good control. And he has a lot of symptoms that affect his quality of life. He's never had sinus surgery. So what additional information would you consider for this patient? One, would you do blood eosinophils and serum IgE? And I actually do it. I actually perform that. I actually do check for blood eosinophils and total IgE in this patient. Would you consider doing nasal endoscopy or CT of the sinus? And I would say for me, as an ENT doctor, I would actually perform a nasal endoscopy. But if you can't do a nasal endoscopy, certainly getting a CT scan to document the nasal polyp is a very reasonable option. For me, I do nasal endoscopy first and then give them additional medical treatment and try to get a post-treatment CT of the sinus. With this history of asthma and nasal polyps, certainly you figure that the asthma may be bad. So getting a spirometry as well as FeNO would be helpful in trying to characterize his asthma status as well. So I think those are all reasonable options for our patients. And so let's talk about chronic sinusitis. So chronic sinusitis, according to the CDC, affects about 12% of the US population. And in fact, some of the databases say it could be as high as 17%. But what's clear is that majority of the patients with chronic sinusitis are without nasal polyps. And these patients tend to be slightly higher among women. Now, if you have nasal polyp, it usually accounts for about 20% or 25% of chronic sinusitis patients. And in fact, they say it's a little bit higher among men, but I'm going to say if you have asthma nasal polyp, actually you're more likely to be a woman, slightly higher among women. And the United States has the dubious distinction of having the highest prevalence of chronic sinusitis, followed by Europe. So, and then there are other countries that have nasal polyps and chronic sinusitis. And in fact, these numbers are changing. So like in Korea right now it's about 7%, but in the years past, it was much lower. So you see that these numbers can change over time. And so when we look at specifically chronic sinusitis with polyp patients, we know that they use an inordinate amount of medical resources. So they increase the use of pharmacy medication use. They have increased of office visits as well as ambulatory costs, which likely includes sinus surgery. So it's not uncommon and it's not surprising that these patients with chronic sinusitis with nasal polyps, which are a little bit more severe and require more medical resources. So how do we define chronic sinusitis with nasal polyp? And so this was well defined in the ICAR document that was published in 2016 and updated this year. And it's actually kind of well defined for a long time. And in order to be diagnosed with chronic sinusitis, you have to have two of these four cardinal symptoms. These are probably the four most common symptoms that we see in our patients with chronic rhinosinusitis. So drainage, nasal congestion, facial pressure, and decreased sense of smell. Now, in order to also diagnose them, you have to have some type of objective finding, whether that be with a CT scan or nasal endoscopy. Now, when you look at patients with chronic sinusitis with and without nasal polyps, we see that of the four common symptoms, we see that the chronic sinusitis with nasal polyp are more likely to have facial pain and pressure, while those with polyps tend to have loss of smell. And here an example of a CT and a nasal endoscopy in someone with nasal polyps. And as you can see on there, patients with nasal polyps tend to have more opacification than patients without nasal polyps. And that's a nasal endoscopy of the right nasal cavity. And you can see that the polyp is coming between the middle turbinate and the septum. So it's actually coming from the olfactory groove. So, which is not surprising why these patients have a loss of smell or decreased sense of smell. Now, one of the things that I think is important when we're treating our patients is, how do you define uncontrolled chronic sinusitis with nasal polyps or severe nasal polyps? And so severe nasal polyps are patients with a nasal polyp score of 4, and I'll go over the nasal polyp scoring system. These are patients with severe symptoms, and they have increased loss of smell, which is different than uncontrolled, because there are some patients who are not severe that have uncontrolled chronic sinusitis. So these are the patients that will likely need intervention. And so what do we mean by uncontrolled chronic sinusitis with nasal polyps? So these are patients who have been on topical steroids and still need some type of intervention, whether it be sinus surgery or a short burst of oral steroids or systemic steroids. And it's not surprising when we look at the comorbidities associated with nasal polyps, we look and we see that patients with AERD or NSAID ERD, also known as aspirin triad, it's not surprising that all the patients with AERD or aspirin triad have nasal polyp, because by definition, in order to have AERD, you have to have nasal polyps. And then when you look at the other type 2 comorbidity, asthma and allergic rhinitis, we see that actually asthma is a better associated with nasal polyps. And in fact, if you have nasal polyps and sinusitis, you tend to have worse disease. So here we're looking at patients with nasal polyps and asthma. And when we look at their asthma, we see that the patients with a nasal polyp are a little bit older. They have usually a little bit worse FEV1. They have higher amounts of sputum eosinophils and blood eosinophils, as well as worse asthma symptom score. And then, and if you have nasal polyp, you're more likely to be associated with asthma exacerbations, more asthma exacerbations. So not surprising. And, as we talked about aspirin triad, NSAID ERD, or AERD, these are patients with asthma, nasal polyp, and aspirin intolerance. Usually, it was historically kind of seen driven by the leukotriene, cysteine leukotrienes, but we're finding out that, IL-4 is a factor in these patients as well. So, let's then jump into the endotyping. So we talked a little bit about IL-4, and let's talk a little bit more about that. So when we talk about chronic sinusitis and we talk about the different endotypes, inflammatory endotypes, there are 3 of them: type 1, type 2, and type 3. Now, out of these 3 inflammatory endotypes, I think the type 2 is the most well-defined, where we see elevation of IL-4, IL-5, and IL-13. And these cytokines play a big role. Now, type 1 and type 3 are not as well defined in chronic sinusitis. They're getting better delineated, but definitely type 2 CRS is pretty well defined. And so when we look at, type 1 versus type 2, I mean, some people see it historically as Th1 and Th2. We see that the ones with type 2 chronic sinusitis with nasal polyps are more likely to have asthma, nasal polyps, or a combination of those two, and especially, and also ARD as well. And as we talked about before, we're noticing that patients with ARD are more likely to be associated and detected with IL-4, but they're hard to detect. So in our study, we were able to identify them using flow cytometry in patients with ARD, but they're definitely not easy to detect. And so when we look at type 2 cytokines, as we said earlier, IL-4, IL-5, and IL-13 are the key players. Now, when we talk about IL-4, IL-13, and IL-5, we kind of see them more along the allergic pathway, having allergens triggering this inflammation. But we're starting to realize that type 2 inflammation doesn't necessarily have to be driven by the allergic process. It can sometimes be driven by viruses and bacterial infections. So you can see these viruses or bacterial infection disrupting and causing injury to the epithelium, and the epithelium's then releasing alarmins or epithelial cytokines such as TSLP, IL-25, and IL-33. And then we can see that Th2 or T helper 2 and ILC2 or innate lymphoid cell 2 can secrete the IL-4, IL-5, and IL-13, and you can see it causing the allergic pathway. We know IL-5 and eosinophils go hand in hand, and IL-13 is responsible for trafficking of the eosinophils. And we know that IL-13 causes globule hypoplasia and mucus secretion, as well as fibrosis, which we commonly see in our patients with nasal polyp. And basically, this whole inflammatory process basically leads to an inflamed upper respiratory mucosa, or eventually leading to nasal polyps. So let's kind of go back to our patient, Bob. So, we see Bob, we can see that based on the definition of uncontrolled and severe, this probably patient has uncontrolled nasal polyps. And in fact, if you look at it, this spirometry and FEV and FeNO, you can see that his asthma is probably not well controlled, and especially with his FeNO being elevated above 25. And this is when he's on high dose ICS and LABA. And I think in these patients with nasal polyp and asthma, you have to ask them, how are they with aspirin tolerance? And so one of the things that I asked them is not only do they have asthma, but when they developed asthma, because we noticed that patients with nasal polyps and adult onset asthma are more likely to eventually become aspirin intolerant. So those are things that we want to certainly consider. So for this patient, he's already been on topical steroids. He's already been on saline irrigation. So what do you do next? And I think sinus surgery is a reasonable option for this patient. He's never had sinus surgery, but I think sinus surgery is a reasonable option. Certainly biologic, especially with his asthma being poorly controlled, a biologic is a reasonable option because he's on high dose ICS and LABA, and he's not well controlled. And so certainly biologic is an option. EDS flu, certainly a reasonable option for the nasal polyp because he's already tried nasal steroid spray and it's failed. And certainly short bursts of oral steroids is a reasonable option. But that's something that you don't want to consider in patients on long-term basis. So let's talk a little bit about some of the medical treatment options that we have. So as we talked before, if someone has nasal polyposis, they'll come to us. They've already been on this stuff. They do nasal irrigation already. They get it over the counter. They get nasal steroid spray, and they've tried this already when they come and see us. And oftentimes, if they're referred by primary care doctors, they've already been on systemic steroids. And because systemic steroids or oral steroids definitely are more helpful than antibiotics. Antibiotics in these patients with these polyps do very little to help them. They notice a better improvement with the use of systemic steroids, and certainly helps with their nasal congestion and improvement of smell. And what happens is that when they're on it, they say they feel good. As soon as they get off it, within a day or several days or even a couple of weeks, the symptoms of congestion and loss of smell start coming back. As we talked about earlier, if they failed nasal steroid spray, certainly exhalation delivery system of fluticasone is a reasonable option. This was approved by FDA in the fall of 2017. And if we look at the pivotal studies, Navigate 1 and Navigate 2, we can see that these patients had improvement in their Polyp score as well as SNOT score. And it also decreased the need for surgery. In surgery, when we talk about certain surgery, we know that it works very well. I mean, we are able to get rid of all the polyps. We're able to decrease the inflammation. We're often doing it as an outpatient surgery center. Some people are now doing it in the office. But the problem with surgery is that it's not a permanent fix. A lot of patients come in, they say, by doing nasal polyp surgery that they get cured of their nasal polyps, but that's not true. And so we know that even with sinus surgery and medical treatment afterwards, the polyps can regrow. And so in a very nice study, they showed that if you had sinus surgery plus topical steroids and other medical treatment, the recurrence rate of the nasal polyp was 40% in 18 months. So that doesn't mean because the polyps came back that they needed surgery again, but certainly they had symptoms and the polyps started coming back despite the use of topical steroids. And we know that patients where it's driven by type 2 inflammation are more likely to have the polyps come back. In fact, most of the patients with nasal polyp recurrence are type 2 inflammation. And certainly sinus surgery isn't without risk. I mean, there are major and minor complications that you can see here. Now, this is from the Galen study from Europe. And so they had patients who had nasal polyps, they had nasal irrigation, steroid spray, as well as systemic steroids. And about half, a little less than half of these patients said that they wanted to or needed surgery. And then of those 46% of the patients who had sinus surgery, they found that about 20 to 35% of these patients had recurrence of their nasal polyp at 6 months. And as we talked about earlier, there was another study in the US that talked about patients with nasal polyps, and they grew back at 18 months in 40% of the patients. And, in this Galen study, what they saw that is about a third of the patients needed a repeat sinus surgery in 12 months. And there are about 20% of these patients required multiple surgeries. So for someone like ARD or asthma triad, these patients often require sinus surgery every 3 to 4 months. And so if you've had sinus surgery, one option is the steroid implant. And so this was a study, Resolve 1 and Resolve 2 study. That was the pivotal study. And what they had was these steroid stents that or steroid implants that released mometasone over a period of 3 months. And so these are patients who have had sinus surgery, and specifically ethmoid sinus surgery. And you could put these steroid implants into the ethmoid cavity, and you could do this in the office. In fact, the way it was designed, it was actually purposely built to be placed in the doctor's office. And the way I often use this medicine is if someone has recurrence of nasal polyp, they say, I want oral steroids. I would say, this could be another option instead of taking systemic steroids. So this is another way of delivering topical steroids into the sinus cavities. And so those are some of the conventional treatment options that we have. So let's talk about some of the new therapeutic options that we have. It's a new class of therapeutic option in biologics for nasal polyps. So one of the questions that comes up is, how do you decide which patient should use biologics or require biologics? So there was a group of international rhinologists, and I was very fortunate to be one of the doctors or authors that was involved in this. And so, we were trying to come up with, what are the, what do the patients have to meet, or how severe do they have to be? And so we said that we have to both define that they have to have nasal polyps, and usually bilateral nasal polyps. And if you've had sinus surgery, it usually means that you're usually pretty severe. So we said that you only have to meet 3 of the listed criteria below. But if you never had sinus surgery, certainly biologic is an option, but you need one more extra criteria to be evaluated to be able to use nasal use nasal biologics for nasal polyp. I'm sorry. And so what are the biologics that are currently available? So we know that in the US, dupilumab was approved in June of 2019. So it was the first biologic that was approved for nasal polyp. You give 300 milligrams every 2 weeks. And then omalizumab got approved in December of 2020. And for that, you give a varying dose of 75 to 600 milligrams every 2 to 4 hours. And it's really dependent on the total IgE as well as the weight of the patient. Most recently, in July of this year, mepolizumab also got approved for nasal polyp, and you give 100 milligrams every 4 hours. Benralizumab finished their phase 3 study. It was actually just recently presented. The pivotal study was presented in Europe, and we have it has not received FDA approval yet. So, as we talked about earlier, when we talked about nasal polyp scoring system, these are the way we define nasal polyps. So 0 nasal polyp score is no polyps. 1 is it has to be within the middle meatus and above the inferior border of the middle turbinate. If it's below the inferior border of the middle turbinate, it's a 2. And if it's a 3, the polyp is down to the inferior border of the inferior turbinate. And then if it's a 4, it means it's completely occluded in the nasal cavity. So in these biologic studies for nasal polyps, the patient had to have a polyp score of at least 2 on each side and a total score of 3. So you can see that these patients have pretty severe nasal polyp. And in fact, some of the nasal polyp scores were up to 6 in some of the studies. And so they also had to have severe nasal congestion. And when we say nasal congestion, this is a patient-reported outcome. And they had to put a scale between 0 to 3, 0 being none, 3 being severe, and 2 being moderate. And in order to be recruited for a study, you had to have a nasal congestion score of at least 2. One of the questions that comes up is this really a good measure, a patient-reported measure for chronic sinusitis? And, I certainly had conversations with the FDA, and I'll tell you, I think, they were right. I think this is a very good measure, and it's probably one of the best measure. I think smell and congestions are probably the 2 best measure for nasal polyps. But for smell, you can, with sinus surgery, you can lose your sense of smell permanently. So sometimes it's not reversible. So I think congestion is a very reasonable option to evaluate in our patients with nasal polyps. So let's look at dupilumab from Sinus 24 and 52. So the difference between Sinus 24 and 52 was that, as the name describes, in Sinus 24, the patients were given dupilumab for 24 weeks, while in Sinus 52, the patients were given dupilumab for 52 weeks. And if you look at the graph on the right side, you can see those are for Sinus 24. And you can see that when they were given dupilumab for 24 weeks, the polyp size and the nasal congestion got better. But as soon as dupilumab stopped, you could see there was a little bit of a sustained effect for maybe about 2 months, especially for congestion. But after that, then the nasal polyp score started to increase as well as the symptom. But in the patients who were given dupilumab for 52 weeks, you could see that the nasal congestion continued to improve from week 24 all the way down to week 52. So if you give them dupilumab, the nasal congestion, nasal polyp score continued to improve. But the endpoint was measured at 24 weeks. So if you look at the improvement in nasal polyp score, you can see that in Sinus 24, it was greater than a nasal polyp score of 2 or higher in about 46% of the patient. And if you look at the polyp score between the placebo group and the treatment group, it's 2.06, which are pretty impressive numbers because in order to be clinically meaningful, it's got to be a change of a polyp score of at least 1. And the sinus 52, similar, you see that the change in the polyp score was greater than 2 in about 50% of the patients. And if you look at the nasal polyp score between the treatment group and the placebo group, it almost reaches 2. And if you look at the nasal congestion, you can see that there's a change in the nasal congestion from about 0.9, a little less than 0.9 for both sinus 24 and 52. And what's clinically meaningful for a lot of these patients isn't so much it is improvement of nasal congestion, but for them, what's important for them is whether or not they have to have sinus surgery or require systemic steroids. So here, what you see is that in patients who were given dupilumab, these patients had reduced need for systemic steroids and sinus surgery by more than a third. And so another way to kind of say this is if patients were given dupilumab by week 52, they were more than 3 times less likely to need sinus surgery or systemic steroids. And for patients, that's what's most important for them. And let's look at, so from what we've seen, it shows that dupilumab is effective in our patients with nasal polyp. Well, how safe is it? So this is looking at a table looking at the adverse effects. And so you could look at the serious adverse effect versus common adverse effects. And on the bottom half of the table, you can see the most common adverse effect. And if you look at the most common adverse effect, it's actually nasopharyngitis. And it's very similar. The adverse effect or the safety profile between the placebo and the treatment group, very similar. And, I wouldn't necessarily say that nasopharyngitis is an adverse effect of dupilumab. In fact, I would say nasopharyngitis is an adverse effect of the disease, right? So these patients with nasal polyps are more likely to get headaches, nasopharyngitis, nasal polyps. So it's not necessarily an adverse effect of the treatment, but more adverse effect of the disease process. So I would say for the most part, it looks like it's very safe. So the other biologic that was approved for nasal polyp is omalizumab. So when in the 2 pivotal studies or the 2 phase 3 studies was Polyp 1 and Polyp 2. And if you look at the change in the polyp score for Polyp 1 and Polyp 2, you can see that there's a change from baseline of a polyp score of 1. And then, so that shows that these patients, that omalizumab is effective in reducing nasal polyps. And this was measured at 6 months, similar to that of dupilumab. If you look at nasal congestion, you can also see that there's an improvement in nasal congestion as well. So compared to the baseline, there was a change of 0.89 for the Polyp 1 study, and for the Polyp 2 was a little less at 0.7. And if you look at the difference between the treatment group and the placebo group, it's a little less. But if you look at the baseline, you can see there's improvement between 8.9 to 0.7. And so then when we look at, so those studies show that the nasal polyp score and the nasal congestion got better. So those are objective and subjective symptoms. But what about the adverse effects? So is it safe? So if we look at the safety profile, again, very similar to what we see with dupilumab, the most common adverse effect defined as being greater than 3%. The worst adverse effect was asthma exacerbation. And the second most common adverse effect was nasopharyngitis, similar to what we saw with dupilumab. And so again, asthma exacerbation and nasopharyngitis, again, isn't an adverse effect of omalizumab. It's an adverse effect of the disease process. And so you can see some of the other adverse effects that you can see. So here is the pivotal data looking at mepolizumab for nasal polyps and congestion. And so is the way that the data is presented is a little bit different. You could look at to see which of these patients had improvement in nasal polyp versus improvement in nasal congestion. And so the nasal polyp score were similar from 0 to 4 on each side. And you can see that the treatment group had greater improvement in the nasal polyp score. So you can see that the treatment group is on the top, and you can see that they're higher in terms of nasal polyp score and change. And if you look at nasal congestion, it wasn't a score of 0 to 4. The nasal congestion was a measure from 0 to 10. And so you could see that which of the patients had improvement in the nasal congestion. And so if you looked at the median change in the nasal polyp score between the placebo group and the treatment group is 0.7. And in fact, the change in the nasal polyp score, the mean change in the nasal polyp score is about 1, a little less than 1. And if you look at the improvement in the nasal congestion, the change in the nasal congestion is change of 3.14. So again, it's a little different than the omalizumab and dupilumab, where they had a score of 0 to 4, and this one was 0 to 10. So if you were kind of looking at a third of it, it'd be a little less than 1 for improvement in nasal congestion. And again, as we saw with the dupilumab study, we see that for the mepolizumab as well, we see that there's a reduced need for sinus surgery. And so by week 24, by week 52, you could see that the mepolizumab group were about 3 times less likely to undergo sinus surgery than the placebo group, which had higher need for sinus surgery, meaning that they had less control of the nasal polyp symptom. And so when we look at the safety data, again, these are the adverse effects that were documented in the pivotal study. And if you look at the most common adverse effects, you see that nasopharyngitis, again, tops the list. Certainly headaches, sinusitis are not something that you commonly see necessarily with mepolizumab, the treatment, but more associated with sinusitis. And so again, these are more adverse effects with the specific disease rather than the treatment itself. And so far what we've seen is that the different biologics that have been approved for nasal polyp have both subjective and objective improvement for treatment of nasal polyps, and the adverse effects seems to be pretty similar between the placebo group and the treatment group, and it seems to be fairly safe. So now that we know that it works and that it's fairly safe, how do we decide to use these biologics in our patients with nasal polyps? And so I think this is where shared decision-making process is important. So let's go ahead and talk about how do we select the biologics. So right now, there are a lot of experts that have talked about, which biologic is helpful and which specific patients with nasal polyp. And, we don't know that yet. And so we're still trying to understand that. But there are certain things that we do know. We know that in patients with severe nasal polyp, as you saw here, that we're seeing in all the pivotal studies, they seem to have a pretty good response to the nasal polyps. If you had comorbid asthma or ARD, those patients also did very well with the biologic. And then, in patients with type 2 inflammation, seem to correlate very well with the response to the biologic. And certainly, you want to talk to them about the treatment options. And I don't think, a lot of people say that, it should be surgery or biologic, but I want to say that sometimes it may be both. Sometimes you may need to do surgery and give them biologics. And as our experience for biologics start to increase, we're starting to understand that you may actually need to do both. And, these patients who respond really well to biologics often have comorbid asthma. And I think that's kind of where it's very important to have a multi-specialty approach where, the otolaryngologists, the allergists, and the pulmonologists kind of need to get together and talk about, what is the endotype and phenotype of this patient and the selection of the biologic. And I think it's very important that it needs to be a multidisciplinary approach. And so once you start them on biologic, the patient should be reassessed at 6 months. And the reason for this decision is because that's when the pivotal landmarks or endpoints were measured, the nasal polyp score and the nasal congestion. And so how do you decide if a patient had a response? Because that's one of the questions that comes up. And the way it was defined by the Euphoria, and this was an update to what was published earlier. They said the response is that they had at least an improvement in one of the symptoms or score. So they had improvement in their sense of smell, improvement in congestion or polyp score, or SNOT-22. And fortunately for the SNOT-22, which is a quality of life measure specific for sinusitis, the MCID was calculated. So if they had an improvement in their SNOT-22 of greater than 9, then it was seen as being a response. One of the things that I actually like is the visual analog score of 0 to 10. And you ask them how they feel. And it's a very simple test to perform and ask the patient. And a reduction of 2 centimeter of that score is considered a response. So if they didn't have a response, certainly you want to talk to them about maybe changing the biologic or performing sinus surgery. If they did have a response, you want to ask the patient, is the improvement good enough? If it is, then I would say continue the biologic. If it's not, then we can certainly talk about doing sinus surgery. So this is kind of where I'm talking. It's not biologic or sinus surgery. Sometimes it may actually be a combination of the two. And so you could do sinus surgery and then keep them under the biologic. And, we certainly had a lot of patients where we did sinus surgery, kept them on biologics, and the biologics have prevented the polyps from going back long term. And certainly, additional use of short-term steroids is another option for our patients. Another time point is to kind of, if they've had a good response, then you can reassess them at 12 months and see if they've had an adequate response. And the way we defined what adequate response was having a nasal polyp score less than 4, where the nasal congestion is mild to none, where the VAS score has a change of is less than 5, so it's 4 or 0 to 4 on the VAS score, or the SNOT-22 is less than 30, and those were kind of seen as a adequate response. If they didn't have an adequate response, we could certainly talk to them about changing the biologic or doing sinus surgery. And if they had a good response, I would keep them on the biologic long term. Now, another way to kind of approach patients with nasal polyp was this multidisciplinary approach to a stepwise treatment for nasal polyps. And the reason why this paper got published was the authors and the experts were trying to recommend the optimal treatment sequence in treating our patients with nasal polyps. And this was more specific geared towards the US population because they were looking at more of the FDA-approved treatment products for nasal polyps, as we discussed earlier. The other reason for writing this paper is to improve quality of care and to reduce variation and cost. And so let's talk about this. And this paper can really be easily summarized by the figure that we see here. And so here, as the Euphoria guideline mentioned, we need to diagnose and establish the diagnosis of chronic sinusitis. So these patients should have symptoms of sinusitis, such as the congestion, decreased loss of smell, facial pressure, as we talked about earlier. Certainly, quality of life measures such as SNOT-22 would be helpful. certainly we want to have not only subjective symptoms, but also have objective findings. And these could be defined as anterior rhinoscopy, nasal endoscopy, or CT scans. And if they have nasal polyp, a lot of these patients have already tried over-the-counter nasal steroid spray. And we say that a 4-week trial of nasal steroid spray the patients should start having some improvement. If they don't, this is where we think that it's important that if the patients are having persistent symptoms or worsening symptoms despite topical nasal steroid spray, I think this is kind of nice where we should kind of endotype on the patient. And so what's kind of clinically available is doing allergy testing, possibly doing aspirin challenge if it's appropriate, checking for blood eosinophils as well as total IgE. Now, if they fail topical nasal steroid spray, certainly using an alternative topical steroid such as the exhalation delivery device, short burst of steroids. Since this was specifically for FDA-approved products, we didn't really talk about budesonide irrigation, but certainly it's a reasonable option. And then if they fail those treatment options, then we need to escalate care. And the experts have felt that majority of the patients, if they never had sinus surgery and they failed these topical steroids, that they would probably benefit. The majority of them would probably benefit sinus surgery. That's not to say that sinus surgery should be the first option, and it's not. I mean, there are some patients where they don't want surgery. There are some patients where they are not candidate for sinus surgery. And in our patient with Bob, they have poorly controlled asthma, or if they're steroid dependent, certainly those patients are ones that you may want to consider biologic first. And so if they had sinus surgery, again, you have to have some type of post-operative medical management. And as we saw earlier, just because they had sinus surgery and good medical treatment afterward doesn't mean that the polyps do not grow back. They can grow back. And this is where I think if the polyps are starting to grow back after sinus surgery and topical steroids, that's where this multidisciplinary approach is very, very important. This is where the allergists, pulmonologists, and otolaryngologists kind of need to get together and talk about, what is the best treatment options. And we need to present the different treatment options to our patients. We talk about biologics, revision sinus surgery, steroid implants, short burst of steroids, or even aspirin desensitization in patients who have ARD. And again, as you saw in the Euphoria, the experts here also agreed that a 6-month trial is what's necessary for the biologic before you would consider that it is a failure. So when we talk about shared decision-making process, what are we discussing? And so when we're talking about shared decision-making process, what we're talking about is we're presenting all the different treatment options to our patients, talking about the pros and cons, and taking the patient's wishes into the treatment plan. And so if they've never had sinus surgery, certainly we could talk to them about biologics, topical steroids, or sinus surgery. If they've had sinus surgery, one extra options that we can consider is using the steroid sinus implant. And certainly revision sinus surgery is an option, as well as using systemic steroids. And so, and if they have a certain type of disease, certainly biologic tends to play a bigger role. So if someone has a concomitant type 2 asthma that's poorly controlled, certainly biologic is another option. Now, when we say sinus surgery here, we know that in patients with nasal polyp, if you do sinus surgery, that also improves their asthma. And so sinus surgery can improve their asthma. And so here's a graph that the American College of Allergy, Asthma, and Immunology got together with the American Rhinologic Society, and they created this shared decision-making tool for our patients. So this is a paper tool that's currently available, and they are currently in the process of creating an electronic version. So in the shared decision-making tool or paper tool right now, is very nice. So you give this to the patient, and it kind of explains everything. It talks about the different treatment options, such as nasal steroid spray, the exhalation, sinus surgery, steroid implant, and biologics. We say, how do you use it? What is it? What are the pros and cons? And we also talk about cost. And when we talk about cost, we're not talking about cost to the healthcare system. We're talking about cost to the patient because that's what the patient is interested in. So when we talk about shared decision-making process and incorporating the patient, we're really making this patient-centric and really taking the patient's interest and deciding what is best for the patient and what is it that the patient wants. So now we talked about all these different information, and that's a lot of information. Let's kind of go back and kind of bring it back to our patient population, our patient case. So Bob, when we go back to Bob, what does Bob have? So we know that he had uncontrolled nasal polyps or also severe nasal polyp. And in fact, he had comorbid asthma that did not seem to be well controlled despite high ICS LABA. And and so what do you do for this patient? So when we're talking about a shared decision-making process, certainly there are two treatment options that seem to kind of float up. And certainly the other treatment options are not invalid, but certainly these two treatments seem to float up. And certainly considering sinus surgery is an option, and you want to talk about the pros and cons for each. And you certainly biologic. And so these are the three biologics that have been approved for chronic sinusitis with nasal polyps, and they're also approved for asthma as well. And so when we talk to them about sinus surgery, we certainly want to talk to them about undergoing anesthesia or missing time off from work. When we're talking about tupolumab, we say that it's the first approved biologic for nasal polyps, so it has the longest track record, but you have to give it every other week. Omalizumab, the dosing is certainly dependent on the total IgE and body weight, and you can give it every 2 to 4 weeks. And mepolizumab, which was most recently approved for CRS with nasal polyp, the dosing for that is every 4 weeks. So those are all the things that we want to talk to our patients, and those are all the information that you want to present to the patient so that the patient is aware of the treatment options. So to kind of summarize everything and to kind of bring it back, we know that chronic sinusitis is very common. And we know that patients with nasal polyposis definitely exist. And it accounts for about 20 to 25% of our patients with chronic sinusitis. Certainly, if patients have asthma, allergies, or aspirin intolerance, certainly you want to consider nasal polyposis in the diagnosis. And when we look at how nasal polyps are developed, we know that it's most commonly associated with type 2 inflammation, meaning that IL-4, IL-5, and IL-13 are what's driving the inflammation in our patients with nasal polyp. So by targeting IL-4, IL-5, and IL-13, we are able to make the nasal polyps better and make our patients better. So improve their objective finding and subjective finding. So improve their nasal polyp score as well as their symptoms of nasal congestion, which I think is a very good measure. And certainly we talk about medical treatment, and sometimes not all medical treatment fails, and that's why we have various treatment options. And I think it's great to have all these treatment options that we have available for our patients, and certainly you want to talk to them about all the different medical and possible surgical treatments for our patients. And as we discussed earlier, sometimes sinus surgery, a lot of patients think that sinus surgery is a cure for nasal polyps, but it's not. And sometimes the polyps can grow back, and so you need to continue long-term treatment. One of the things that I try to tell our patients is chronic sinusitis with nasal polyps, meaning that once they have nasal polyp, they're going to pretty much have nasal polyp for life because it's a chronic disease. It will never, ever go away. And fortunately, we have a new class of treatment options for our patients, which are the biologics. And now we have 3 biologics that we can choose for our nasal polyps. And I think shared decision-making process is a very important process to consider. So with that, let's do our post-test polling. So let's do our polling question again. So what are the primary cytokines involved in type 2 inflammation? The most common endotype associated with CRS with nasal polyp. So here, go ahead and answer the question: interferon gamma, tumor necrosis factor alpha with IL-6, IL-4, IL-13, and IL-5, or IL-17, IL-2. So go ahead and pick your choice and submit that. So I'll wait a little bit and let people answer that. Okay, so let's go to the next polling question. Which biologic showed improvement in the nasal polyp score of 2 or greater in close to half the patients who received a biologic at week 24 and 52? And so go ahead and submit your answers. So it's benralizumab, dupilumab, mepolizumab, or omalizumab. All right, let's go to our next question. What is the most commonly observed treatment adverse effect in the clinical trials for all the biologics studied for chronic sinusitis? Is it epistaxis, a local site injection reaction, nasopharyngitis, abdominal pain? So go ahead and choose your um, answer and submit your answer. Okay, let's go to our next polling question. So, Mr. Brown, a 42-year-old male with chronic sinusitis with nasal polyps, had recurrence of nasal polyps after 12 months. And as we talked about earlier, we know that type 2 inflammation is driving the nasal polyps. And so, based on the euphoria guideline that we talked about, what does this patient should be the next treatment option? Should it be return of medical management with short bursts of steroids? Should it be a biologic or revision sinus surgery? Should it be an exhalation system or a steroid implantable stent? So, which one would the euphoria, based on euphoria guideline, recommend? Right. Right. And so this is the last polling question. So Mr. Brown, feeling discouraged that the polyps are going to grow back anyways, he didn't want to go through all the expense and pain and downtime undergoing sinus surgery. So we talked about shared decision-making process. So what would that mean, or how would we define that? And so one, advise him to consider sinus surgery, apprise him of the guidelines, and ask him to decide between the two treatment options. Do we give him information about all the available biologics and ask him to choose one? Or do we let him know all the therapeutic option and talk about the pros and cons of each? So, what does a shared decision making process look like to you based on the available treatment choices? Right? Sounds like everybody paid attention and did a great job. And so now I know we have a couple of minutes left, and I want to open it up for any um, questions that the audience may have. So we have one question. So it says type 3 inflammation was covered a little bit, and we know it's mostly driven by IL-17 and IL-22. But how do we recognize this endotype in a CRS patient? That's a great question. It's actually interesting. If you have a lab like me where we're able to endotype the patient in our lab, whether it be through immunohistochemistry, flow cytometry, and we actually try to measure IL-17 using flow cytometry. It did not work very well. So we ended up identifying IL-17 in nasal polyp patients using immunohistochemistry, and that seemed to be the best way to define it. And we know that IL-17 is not all the same. There are 6 different subtypes of IL-17. And so most people can't do that, right? And that's what makes it so hard. And so we talk about endotyping our patients with chronic sinusitis so that we can kind of know which biologic would work a little bit better. But that's something that most clinicians can't do. So unless you have a lab, you can't endotype these patients. So, the thing that I try to do is correlate the phenotype to the endotype. And so we know that certain symptoms correlate to a type 1, type 2, or type 3, as you saw earlier. And then there was a really nice paper by Stevens and all that talked about the certain symptoms that are associated with type 1 and type 2. And, another way to kind of look at it is looking at comorbid disease. And I think that's why I think type 2 is such an easy one to identify. So we know that allergy, asthma, ARD are seen as type 2 comorbid disease. And if they have this, you know that they have a type 2 driven process. Type 1 and type 3, again, as we said earlier, is still being characterized, is still being better defined in our patients with chronic sinusitis. And so thank you for that question. And I think we've come to the end of our discussion. So I just want to thank the audience for attending our lecture today. And there are additional resources and information related to chronic sinusitis with nasal polyp. So please visit this website, integrityce.com/CRS with nasal polyp resources. And so you will now be redirected to the evaluation, or you can claim your CME credits at integrityce.com/CRS with nasal polyp post eval 3. So thank you for joining us tonight, and